Good morning, everyone. We'll start with introductions real quick, and then we'll transition over to Dr. Frosh's presentation. My name is Nemeka Eze. We are really excited to welcome you guys to our sixth session of PPP, which is Pete Speaks for Practice, which is an initiative that is aimed at empowering decision-making from pediatric images for those who are caring for children. Our speaker today will be Dr. Donald Frosh, who is a professor of radiology and at Duke Department of Pediatric Radiology, and who has been an integral member of the team in making sure that these sessions are happening on a monthly basis. This session our topic is how to read X-rays, getting some color from the black and white, and Dr. Frosh will be taking us through that. We just want to remind everyone that if you have not registered already, please try and register. This is a way for us to keep track of attendance for the purpose of providing you with a certificate recognizing that you have attended these sessions. We also would appreciate if you give us some feedback on how the program is going. At the end of this session, we will actually go over some of the feedback you've already given us in the last 5 to 6 months. Just so that we can discuss any issues that may be in existence and make sure that the program is getting better each month. Materials presented here today are only for educational purposes. It's not for further dissemination beyond the educational purpose. We will provide you with PDFs of the slides, and we are recording this session as well. And we have a YouTube page where you can watch the recorded sessions in case you maybe had a internet connection issue, you were not able to attend for the full duration, or you want to reference the teaching again. So those are available on our YouTube page. For our session 5, that was done by Dr. Broda, I have the slides that I will also send to you after this session. I apologize for the delay with that. It's a pretty large file. We'd like to recognize our partners who provide us with expertise, Duke Surgery, Duke Radiology, Imbara University of Science and Technology and Regional Referral Hospital, and also the World Federation of Pediatric Imaging and the International Society of Radiology. With that, I'll turn it over to Dr. Frosh. You can start sharing your screen now, sir.
Can you see my slides?
Yes, I can see it now.
Okay, good. Well, thank you for that introduction and welcome everyone. I'm sorry I can't talk with you in person, but one of the beauties of radiology is we're able to do this global type presentation. So the following material will be primarily looking at how you might be able to interpret examinations, mainly chest and abdomen examinations, as well as some of the things that we look for. And it isn't going to cover everything, but hopefully will give you some fundamental perspective on looking at X-ray studies. So the outline is we'll talk a little bit about how I approach the systematic review of plain films, deal a little bit with support apparatus, and end up with some select emergent or urgent conditions on chest and abdomen X-rays. We will have a little time for question and answer at the end of this. I'll try to finish about 10 minutes to the hour. So with the chest X-ray, which I've illustrated here, there are 5 areas that one needs to look at when looking at the chest X-ray to be sure that you have a comprehensive evaluation. Some of the things are obvious and some of the things are more subtle. So what are those 5 areas? Well, they're basically the lungs and the airways, things that are filled with air, right? So the trachea and the lungs, heart and mediastinum, so the soft tissue within the chest here. So heart and mediastinum. The pleura, remember that's a, excuse me, a potential space in the lungs. It's not part of the lungs. It's not part of the chest wall. Things like effusions, calcification, pneumothorax, etc. Bones and soft tissues, things outside the chest, clavicles, ribs, etc. And then the upper abdomen. So as you can see, these 5 things, that's part of the 5-4-3 rule, will let you know that you have looked at everything in the chest. And the reason for that is because sometimes you might see something in the lungs like a pneumonia or a mass, and neglect to look elsewhere, like the bones, to see if there's involvement there. Is an infection with osteomyelitis, etc. So 5 things for the chest. Remember, the technique for the chest should cover the apices, so you need to see the upper part of the lungs to below the hemidiaphragms. Remember that the diaphragms are domed, so there's actually lung that comes posterior here, and that's one of the occult areas in looking at chest x-rays. Those occult areas are behind the hemidiaphragms, where there's still aerated lung, behind the heart, and then the lung apices. So those 3 areas are target areas that people tend to overlook. When I talk about inspiration, you want to make sure that the lungs are well filled, and generally somewhere between the 8th posterior rib and 10th posterior rib is a good inspiratory effort. This is particularly useful in dealing with patients you might have who are in the intensive care unit, aren't able to take voluntary good breaths in, infants, etc. You want to try to get or have an examination that gives you that sort of inspiration between the posterior ribs, the 8th rib and the 10th rib there. Above that can be hyperinflated. Below that is hypoinflated. Now, I just put some normal chest x-rays up here for you all to see, and basically nice symmetric aerated lungs. Your heart and mediastinal tissues are here. This is a 7-year-old, and on the right here is a 7-month-old. And we'll talk a little bit about the nuances of a differences between a newborn or infant chest and adult chest, particularly related to the thymus gland. Now, it's not my intent to go through the various mediastinal landmarks here. For example, this is the azygoesophageal recess, this little edge right here. These are things that radiologists look at in terms of pathology, but it's important for you as we go through the following films to at least get an idea of what the range of normal chest x-rays look like here. So, as I talked about, the thymus gland is something that obviously is a normal organ, and it is proportionally largest in infancy, but it's actually the largest by weight in pubertal years, teenage years. And the reason that we see it well in infancy is because the relative size of the thymus to the chest is bigger, and the thymus gland still gets bigger as you get older, but the chest expands so much more, so you don't see it quite as well in the older children. Basically, you can see a thymus normally up to about 5 years of age. From 5 to 10 years of age, it may present a mediastinal prominence, but after 10 years of age, you usually don't see it radiographically, and that's when you need to pursue something other than just saying it's a normal thymus, say get an ultrasound or a CT examination. Here are just some examples. Now, this is a neonatal chest x-ray. We've got good inspiration. Look, we're at least 8 posterior ribs. Here are your posterior ones, the more horizontal ones. Your anterior ribs are a little more obliquely oriented. This is the thymus gland here. Another chest x-ray, thymus gland, and it tends to be more prominent on the right in infants than it is in the left, but you can see it's obscuring some of the other mediastinal landmarks. So this is all thymus gland here, this sort of sail-shaped organ here. Now, if you have this kind of appearance in a 10 or a 12 or a 13-year-old, it would be abnormal, and you would need to consider things like an anterior mediastinal mass. Here's a much more prominent thymus here. You see it extending all the way down here. And one thing about the thymus, too, is it's fairly thin. And so when you look at the tissues that are thicker, like the heart, they're whiter than the thymus gland, which is thin. See how it's a little bit more gray? It's less white than the heart. So that's another clue to the thymus gland there. So it's a prominent thymus on the lateral view, which you see. It's an anterior mediastinal structure. This, of course, is the heart right back here. And the thymus gland actually extends all the way down to the hemidiaphragm here. So just be aware in infants who are relatively healthy that the thymus gland is going to be more prominent. So now we have a 14-year-old here, and you can see there's some elevation of the right hemidiaphragm, right? We're looking at all our structures. We're looking at the lung or areas. The lung, you want to look at the pleura, which is okay. The pleural space is okay. The bones and soft tissues are okay. Upper abdomen. But there's way too much soft tissue here. Now, as I said, if this is a 14-day-old or perhaps a 14-month-old, you might consider that normal thymus, but it's not. It's a 14-year-old. So this is an abnormal chest X-ray, abnormal mediastinal appearance here, and this is anterior mediastinal. Okay, so here is on the lateral view, this is your anterior mediastinum here, and it has too much white. So this was lymphoma. Now, remember, talking about the 5-4-3 rule, and I'll talk about the 4 and the 3 because I've just talked about the 5 with the chest X-ray, but the 4 part of that applies to an abdomen film, and the 3 applies to extremities. So we're looking at a chest X-ray here. This is a child, maybe 2 years of age, normal lungs. Your heart and mediastinum look pretty good here. No pleural thickening or pneumothorax. Upper abdomen is normal, et cetera. But you look over here and see the sclerosis there in the proximal right humerus. That's abnormal. Here's the comparison on the left side. This is normal bone. This is abnormal bone. This child came into the emergency department with a near drowning history and fortunately was resuscitated. But this was an occult finding here on a near drowning case here, which is an illustration of why it's important to look at everything here. You might just say near drowning, we want to make sure the lungs are okay. Once you do your primary survey, lungs are fine. Hey, this kid is going to do okay. You still have to have those 5 checklist areas that you look at. And this, now you have to be suspicious because you have what is a subacute fracture here in a child with near drowning, and you have to really worry about supervision, non-accidental trauma, things like that, and that needs to be part of the conversation. Now we'll go to the abdomen. So we're going to the 5-4-3 rule. What are the 4 areas in the abdomen? And they're very similar to those in the chest X-ray. That is, you want to look at the bowel gas, obviously. Is it too little? Is it too much? Are there dilated segments of bowel, et cetera? So look at things in the abdomen that contain air. Look at things in the abdomen that are soft tissue, like the liver in the right upper quadrant. Your spleen, it's going to be right here. Are the bowel gas, are the segments of bowel displaced by something soft tissue? Is there calcification where the gallbladder is or in the kidneys here? So soft tissues, and of course you want to look at the extra abdominal bones and soft tissues. We get a good look at the hips, the pelvis, the spine, and the ribs. And the final thing in the 4 areas in the abdomen are the lung bases, and those should always be included in an abdomen examination. Now, if you think about it, 5-4-3, the 4 in the abdomen are very similar to the 4 in the chest. Things that contain air in the chest, things that contain air in the abdomen, bowel gas. Things that are soft tissue and solid in the chest, heart and mediastinum. Things that are solid and soft tissue in the abdomen. The liver, where the liver is, where the spleen is, where the kidneys are, et cetera. Then the extra abdominal, like the extra thoracic bones and soft tissues. And then for the chest, remember, it's look at the upper abdomen. And in the abdomen film, look at the lower chest. The only thing that's different there is there's no pleural equivalent in the abdomen. So we don't have that 5th checklist item. So 5 for the chest, 4 for the abdomen. Now, this actually was a little appendiculate here. I think it's difficult to see, but I'll show a better example here. And this is an example of what you want to do from a technique standpoint. You have to go to the symphysis pubis and you have to see the lung bases. That's a complete abdomen examination. Now, one thing to remember in an abdomen examination, again, if you're looking and you're remembering your 5-4-3 rule and the 4 things you look at in the abdomen, always look at the lung bases. This is a child that presented with abdominal pain, and it's not uncommon in kids who are preschool, 5, 6 years of age, sometimes even in older kids, to present with pneumonia that causes abdominal pain. So the bowel gas pattern here is quite normal. Everything is normal, but if you look at the lung bases, remembering your 5-4-3 rule, you'll see a pneumonia, left lower lobe pneumonia that's causing abdominal pain. Another case here, bowel gas. This is colon, and it's okay. The solid organs look all right. The bones are okay. But look at that left base. See the white behind the heart? It's way more white here than it is over here. And there's a pleural effusion. So this is another example of a pneumonia that's presenting as abdominal pain. And what I'm showing you here is just to remember 5, 4, 3. Look at the 5 areas in chest, 4 in the abdomen. Make sure you're not overlooking anything. And then I'll talk about extremity films here. Now, this was an interesting case just from a couple of weeks ago. It was actually a spine film, which is why they didn't include the entire abdomen on here. So we're looking at the lumbar spine, and the spine actually was fine. But if you look right down here, there's a little density, and it's tough to see on the lateral view, but it's really shaped right here. See that? And it's shaped like a tooth. So, and the patient presented with abdominal pain, but we said, hey, there's some abnormal density here. Perhaps you should pursue this. And they actually did get an ultrasound of that area. And here is the left adnexa, and you can see some fluid and maybe some increased echogenic material right here. And here's the CT examination. And as you can see, this is the tooth right here, and this is a germ cell tumor, a teratoma, that was seen in the abdomen film as an illustration of you need to look at what the people are asking for. In that case, look at the bones and the disc spaces, but you have to remember your checklist, make sure you go through there. And so this hopefully will be a mature teratoma removed, and that will not be an issue in the future here. As I put up chest x-rays to show you normal, I'm putting up 2 abdomen examinations here to show you normal. Okay, this is an 8-year-old, and this is an 8-day-old. And I'll go through a little bit about what we look for in the abdomen examinations. Again, we've included the lung bases and the symphysis pubis region, so these are technically good films. Now, the colon, as you know, is allowed to be bigger than the small bowel. And we have some measurements in adults, sort of 3 centimeters for small bowel as a maximum dimension, 6 centimeters for colon, and 9 centimeters for the cecum. Now, that's not going to work with an infant, right? Because if you have a 9-centimeter cecum, that's going to occupy the entire dimension of that infant. So basically, what you can do for a rule of thumb, or when is a bowel segment potentially dilated, is look at the interpedicular distance at about L4 here. So, and that's a good scale, particularly the first year. If it's bigger than that, you have to consider that the bowel's dilated. If the caliber of the bowel you see, and this is a normal caliber here, is less than that interpedicular distance at the lower lumbar spine, then it's probably okay. Now, sometimes colon is difficult to distinguish from small bowel in an infant. And just remember that the colon course is like a picture frame here, okay? Ascending, transverse, descending, and rectosigmoid colon here. And the small bowel, it's going to be in between all of that there. So this is going to be colon here. This is not small bowel. This is the frame of the picture with small bowel in between. Now, the things we look for with bowel gas pattern, I won't go into great detail here, but just so that you all know the kinds of things we look for, and there are actually quite a few. So you want to look at the distribution, right? Is there a little bit of bowel gas and not much here? And this is abnormal. We usually see more bowel gas, so the distribution here is abnormal. Is it only within small bowel, perhaps that is dilated, and large bowel doesn't have any gas? That's an abnormal distribution and may indicate a small bowel obstruction. Excuse me. What is the character of it? Is it just a few O's and C's, some comma-shaped bowel gas distribution, or is it sausage-shaped? Sausage-shaped is a bad shape of bowel there. You don't want to see that, and I'll show you an example of that. Is the wall thick or not? Generally 2 to 3 millimeters is the separation we see between bowel segments. If you've got more than that, you might have some wall thickening. Is gas within the bowel, the colon, the stomach, or the small bowel, or is it outside? The outside bowel gas things that we see are, excuse me, pneumatosis, portal venous gas, and pneumoperitoneum, and I'll show you some examples of those. And does the bowel gas change with time? If you think about it, your bowel is constantly peristalsing. Gas should be distributed even 5-10 minutes later differently than it is. It should be distributed differently. If you have persistent bowel distended segments over an hour, 2 hours, 4 hours, etc., then you have to consider that that's abnormal. So these are the kinds of things we look at, and I'll show you an example here. So this is actually a child from this morning. I put this in the talk because I think this illustrates nicely some of those things we're talking about. Excuse me. So here we've got the lung basis to the symphysis pubis, and this is a cross-table lateral view. And there are a number of things wrong here. See, first of all, there's pneumoperitoneum. See that right there? That is free air in the abdomen, and it tends to, on the lateral view, accumulate up towards the liver here. Sharp edge right here. This is not within bowel. So this is free air. There's also portal venous gas. See this branching lucency in the liver right here? That is abnormal. And then there's pneumatosis. There's bubbly lucencies in the bowel wall. And see these sausage-shaped loops? These are abnormal. Again, it should be little C's and O's distributed throughout the abdomen. Also, there's wall thickening. So this case illustrates many of the things I talked about when we're looking at what's normal and what's abnormal. And this is a child that has necrotizing enterocolitis, had pneumatosis intestinalis, and portal venous gas, which is the next worst stage of necrotizing enterocolitis, and actually perforated here. So that's pneumoperitoneum. Now, the final thing for the 5-4-3 rule are the extremity examinations. And when you think about it, chest, abdomen, and extremity examinations constitute about 99% of all the X-rays we do. So if you remember the 5-4-3 rule and those things which you need to look for and at, I think it will be helpful in your looking at films over the future. So what are the 3 areas you look at with bone films, whether it's an ankle, a wrist, a hand, etc.? Well, you want to look at the bones, right? See if they're normal or they have a focal lesion or a fracture or something. You want to look at the soft tissues, right, of the hand or the ankle, the knee, the elbow, etc., and see if they're normal or abnormal. It might be calcification, it might be swelling. And you want to look at the relationships of the bones to each other, the joints, right? Because your bones may be normal, but if you have a dislocated phalanx here and here, the relationship is going to be abnormal. So the bones are okay, the soft tissues may be okay, but the relationships of the bones to each other is abnormal. So those are the 3 things to look at with extremity film. So the bones, the articulations, or the relationships of bones to each other, and the soft tissues. So as you're looking at this examination here, what should strike you is, if you think about the back of your hand, it's just bones, right? It's bones and skin. There's way too much soft tissue swelling right here. See that? So that's a clue that there's something going on. When you look closely, too, there's a very subtle fracture right there of that probably 5th metacarpal. But this is way too much soft tissue swelling here. So just an example of the things you look for extremity examinations in terms of the 3. So the checklist, 5 for the chest, 4 for the abdomen, 3 for the extremity examinations. And if you keep this in mind and sort of embed that in your clinical practice, I think it's going to be helpful for you to understand when radiologists look at examinations, what they're looking for, but the times that you may be required to look at them, what kinds of things, where the areas are to look at. So I'll move on now past the 5-4-3 rule, and we'll talk a little bit about some abnormalities. But first, I just wanted to bring up one thing, because it does come up sometimes, and that is with relation to radiation that we give in medical imaging. And I just put some examples of different studies here: an ankle film, a chest X-ray, an abdomen CT. And you can look at the chest X-ray equivalent. So obviously a chest X-ray equivalent is 1, but an ankle film is much less dose than a chest X-ray equivalent. And of course, depending on how you do it, the CT examinations can be many more chest X-ray equivalents. But sometimes it's most helpful to put those in terms of what's the equivalent to the background radiation, the stuff that we get every day. You get it from sun, you get it from the food you eat, you get it from radiation in the ground, and we usually get about the dose is millisievert, and you don't need to know that unit. That's why I put these equivalents up here. But you get about 0.008 millisieverts just every day from living. So the ankle film provides a radiation dose, but it's just a few hours worth of background radiation, not much at all. Even a chest X-ray is a very low dose of radiation, 2 to 3 days. So it's just something to remember in your practice, perhaps conversations with your colleagues or in parents or patients that you may be taking care of, that you can reassure them that from a radiographic standpoint, the doses that we deliver are actually quite low. Now, let's look at lines and tubes, complications, and diagnoses here. I'll talk about the endotracheal tube positions, umbilical venous catheters, and umbilical arterial catheters and neonates. Won't deal much about nasogastric tubes, but then we'll talk a little bit about peripherally inserted central venous catheters. So the support apparatus, I think it's important to know about here. So the endotracheal tube location, it's really quite simple because we have anatomic landmarks. The problem in dealing with measurements of tracheal length and the endotracheal tube is 2 centimeters above the carina or 15 millimeters or 3 centimeters is that in the preterm infant, the very young infant, that trachea may only be 11 millimeters. So if you're talking about 2 centimeters in an 11 millimeter trachea, that means that that endotracheal tube is very, very high. So anatomic landmarks are what I deal with, even in the teenage kids, because you want your endotracheal tube to be between the thoracic inlet and between the carina here. So how do we determine these things here? So your thoracic inlet is anatomically defined by the first rib. Below the first rib is where your lungs are. And you always know where the first rib is, and it doesn't matter if it's angled a little bit. And if you just simply draw a line between the mid portion of the first rib here, that is your thoracic inlet. So that's a landmark. Above that, the endotracheal tube is too high. Now, the carina is easy to see because you can see it on the X-ray here. It's where your right bronchus and left bronchus branch. So your carina is right here. So now you know, just based on anatomy, exactly where your endotracheal tube should be, below the thoracic inlet or above the carina. So again, I would discourage using measurements. And times you look at films or discuss the location of the tube, just describe the anatomy. It's below the thoracic inlet, mid-thoracic trachea, above the carina, something like that, because that always conveys to the individuals you're speaking with, whether they're patients or providers, where the tube is exactly. Now, here's a tube, and if we're talking, there's obviously a gastric tube and an umbilical catheter. This tube is too high, right? Because your thoracic inlet is right here. It's defined by the mid portion of the first rib, so it's too high. Your carina is down here. Another example, this is a patient with scoliosis repair, a little bit rotated. And where's the endotracheal tube? Well, your first rib, your right first rib is here. Your left first rib is somewhere around here. So your thoracic inlet is going to be right here. Is this tube too high, too low, or in good position? It is too high because it's above the thoracic inlet. Now, conversely, you can have a tube that's too low. So you can always see the carina. This one ends up being in the right bronchus here. So this tube is too low. Now let's talk about malposition of the tube. This is dilated tubular structure here. You see the gas within that, a lot of gas, within the abdomen here. This is actually an esophageal intubation. So you need to be mindful if you see a lot of air in the esophagus, a lot of air in the upper abdomen, that may be an esophageal intubation, which is obviously an emergent situation. Now, umbilical, arterial, and venous catheters, these are catheters that go in neonates because they have that umbilical structure that has arteries and veins in it. And we'll talk a little bit about appropriate location. So the umbilical arterial catheter should be between about T6 and T10. This one is too high. Your umbilical venous catheter should be just into the right atrium or below the right atrium, right in this area right here, and this one is in the liver. If you remember your anatomy, the umbilical vein is an anterior structure in the abdomen, comes into the left portal vein, crosses through the ductus venosus to the left hepatic vein, and goes into the right atrium. Now that's a fetal structure that ends up closing hours to days after birth. But this line, which is through the umbilical vein, here's the umbilicus, is in the liver, and this is malposition. That is not a good position. Now we talk about a PICC catheter, a peripherally inserted central venous catheter. These are put in veins in the lower or upper extremities, and they have a different course, obviously, than the umbilical venous catheter. This is a right lower extremity PICC. So you're coming up here in the abdomen here, and you really want this to the right side, upper abdomen, maybe T11 or T12 here. This umbilical venous catheter is a little bit low. It's probably okay, but you don't want it in the liver, and you don't want it in the atrium. So that's the tip of the PICC right there. If you look on the lateral view, the PICC, because it's in the conventional venous system, not the fetal venous system, is in the inferior vena cava, coming up towards the liver. So this is really good position. I've highlighted this in yellow here. Your umbilical venous catheter, remember your umbilicus is here. Catheter comes in the umbilical vein, goes into the liver, and it's up towards the top of the abdomen here. So this is good location for umbilical venous catheter here. This is a right upper extremity PICC. And if you think about the venous anatomy in your upper extremities, right, you have subclavian vein coming to brachiocephalic vein to superior vena cava, and this is the top of the right atrium here. So you'd like to see that line inserted peripherally to come this course here, and this one is not. It's going down some tributary into the chest wall. So, and this probably is an umbilical venous catheter. It's good. It's in the right lower atrium, and of course your gastric tube is appropriate in the projection of the stomach. So let's talk about some emergent and urgent complications here, both in the chest and the abdomen in the final 20 minutes or so. And we'll start with the pneumothorax. So there's a child, post-operative, has some sternal wires, heart surgery, a feeding tube is here. Is this a pneumothorax or not? It's kind of more loose in here at the left costophrenic sulcus. And this is a classic fooler of a pneumothorax. It's just aerated lung. And here's a film taken later. It's just the heart margin here, the chest wall here, and the hemidiaphragm. So it looks like a pneumothorax, but it's actually fairly symmetric with the other side. Let me go back to this here. So don't mistake this for a pneumothorax. Now, if we see this case here, this is much more clearly a pneumothorax here. Large lucent area, no markings here. See, there's a depression of the hemidiaphragm here. The child's intubated, so this is a tension pneumothorax because they're on positive pressure ventilation. This has not only resulted in a large air collection outside here, but see, it shifted the heart and the mediastinum over to the right, causing some parenchymal opacification here. So this is certainly an emergent situation which would require a thoracostomy tube. Another case may be a little bit more subtle, but you can see the outline of the lung right here. This is air. Look, you want to look for vessels. If you see vessels in the course of the lucent area, then it's probably not a pneumothorax. You might see a tiny, tiny white edge, which is the pleura here. And again, you see it's a little bit darker down here than it is here. A little bit of shift to the heart and mediastinum to the right too. In this intubated patient, this would be a tension pneumothorax. Another case here, example of a large air collection on the left side, intubated patient. Normally your lung, if you have a normal lung, it's going to collapse down to a really, really small nubbin here centrally. So what this says is, because this is staying white and somewhat inflated, that this is diseased lung. I don't know if it's pulmonary edema or a consolidation or some chronic lung change, but this just indicates, because of the large pneumothorax, that it's not collapsed down here all the way, that this lung is abnormal. This is all air. This is a pneumothorax. There's probably a little collection here as well. And of course, this would need a thoracostomy too. Now we'll move down to the abdomen and talk about abnormal air collections. I already talked a little bit about, when we look at those various features of the bowel, is air in the wall, which is pneumatosis, is air in the portal venous system, because the air in the bowel wall drains up through the mesenteric veins and forms the portal vein. That's why air in the bowel wall can get up to the liver. So is there air in the portal venous system, or is there pneumoperitoneum? And here, if you remember back to what I talked about bowel gas pattern abnormalities, this is sausage shaped, okay? Hot dog, sausage. This is not normal bowel gas pattern here. Now, it's not dilated, so we're not dealing with an obstruction. But as you look more carefully, you can see there's this large lucent area in the middle, and this is free air, pneumoperitoneum. There may be some calcification over here, and it may be contributing. There may have been some in utero bowel perforation with dystrophic calcification. That's pneumoperitoneum. If you do a cross-table lateral view, remember air collects up. This is the high part of the abdomen. Your free air isn't going to collect down here. It's not going to collect here. It's going to collect up here. So look carefully at the upper abdomen, just below the hemidiaphragm for free air. And see this sort of sharp edge right here? Air in bowel stays like an O. It stays like this. It's a smooth edge here. This sharp appearance here is pneumoperitoneum. Now, what's the best way to look for pneumoperitoneum? The supine film manifests air this way, and this is a lot. Sometimes it can be very subtle. The cross-table lateral, particularly in unit patients, sick patients, and so on, is a very good film to do. Some people like to get decubitus. That's putting one side down, and we typically put the left side down so air would rise up over the liver onto the right is another thing to do. But that's sometimes hard in these unit patients, and I'm fine just looking at the two-view abdomen, the AP, and the cross-table lateral, because you usually see the free air well on one or both of those examinations. Now, here's another case here. Remember, we're talking about what we look in bowel gas, and this again, see the wall thickening here? See how it's separated here and here and here? It shouldn't be that way. And this mottled lucency here, this is pneumatosis. We talked about portal venous gas, branching lucencies here. So you would worry about pneumoperitoneum. And then this child proceeded to perforate here. And this, again, this large lucency mid-abdomen here, what we call the continuous diaphragm sign. You shouldn't normally see this edge all the way across. It should stop here at the spine from the left, stop here from the spine from the right. Pneumoperitoneum here. And on the cross-table lateral, a marked amount of free air here anterior in the abdomen examination. Now, again, pneumoperitoneum or not, yes, right here, see that central lucency. That is not, this is normally liver, right? You shouldn't see air here. And there's probably a little bit below. This may be the hemidiaphragm right here, because this is rib, this is rib, this is rib. This is not a rib right here. So pneumoperitoneum here. This is massive pneumoperitoneum. See this continuous, what we call the continuous diaphragm sign? All of this is way too loose in here. You could get a cross-table lateral to confirm that, but this is pretty obvious here. Now, again, remember, you have to look at everything. You have to look at lung bases. You have to look at support apparatus. And this endotracheal tube, is it too high? It is, because here is your thoracic inlet, so that may need to be repositioned as well. This is a left side down decubital film showing air collecting over the liver. Another left side down decubital film for a little more subtle air collecting over the liver. And this is where it collects here, sort of the upper margin of the liver here. All right, let's talk a little bit about white lung before we finish with some foreign bodies. And part of the problem with the white lung is what's causing this? Is it because there's lung parenchyma that's abnormal? Is it a big pneumonia, or is it a huge pleural fluid collection? Or a white lung can be from collapsed lung because there's no air into it. And how do you determine, what the cause is? Because they may have different management, right? If you have a large pleural fluid collection, you might need to aspirate that or put a chest tube in. If you've got a collapsed lung, you certainly don't want to try to aspirate that. You may need to intubate the child or change your ventilatory settings, or try to get that inflated in some way. And one of the main ways that you can tell the difference with a white lung about whether it's collapsed or not is what does the heart and the mediastinum do? With collapse, it's going to move towards the area of whiteness. And if it's not collapse, if it's pleural fluid or if it's a pneumonia, it's going to shift things away. And you can see here, there's a slight shift towards the left. So this is parenchymal opacification, maybe some pleural fluid, maybe it's a consolidation of the lung. If you needed to separate those things out, what would you do? Of course, you would get an ultrasound to look for those different things here. So look at how structures are. Are structures shifted towards the area of white or away from the area of white? One other thing you can look at too is sometimes the inner spaces for the collapsed side are narrower. If this inner space is narrower than this inner space, if this inner space is narrower than this inner space, then you would more likely say that that's going to be collapse. Again, volume loss. And here the inner spaces are preserved. So you can be fairly confident that this is going to be consolidation and or pleural fluid. Now here's another case here, and we'll see if this clip plays. Right, we've got a white lung, right? So is it pleural fluid? Is it consolidation? So we have some clues, right? So the trachea and the heart are shifted over here. Normally you see heart really well right here. If you look at these inner spaces, these are a little bit more narrow on this side than they are on this side. And you can see some inflation of the right lung over to the left here. Now, if this plays, let's see if it plays. This was a child that had surgery, and this large aneurysm of the aorta caused narrowing of the airway. Let's see if we can play that again. Caused narrowing of the airway. It's not going to play again. So this was collapsed left lung. This is all collapsed lung here on the CT. Now we look at this one. Okay, is this collapsed lung or we've got nearly a white lung? And, you know, it's not as helpful here, but certainly the heart and mediastinum aren't shifted towards the side of white. If anything, you're seeing more mediastinum over here. You're seeing a little more heart, and the trachea isn't shifted, a little bit of a meniscus. So this is probably a combination of fluid and consolidation along here. And we got a CT of this patient here, and we'll go back to this. And you see this is a little bit wide right here. And we can confirm that it is not collapsed lung. That's a patient with lymphoma, and there's going to be lots of abnormalities here. There's mediastinal mass, but there's a large left pleural fluid collection as we come through this coronal plane. This is all lymphoma here, pleural fluid collection shifting things over. So you don't want to like intubate this patient and say we're going to re-expand that lung because it's not collapsed from the standpoint of that causing the whiteness. And one thing you have to remember with large anterior mediastinal masses, particularly lymphoma, is always to look at the airway. Lymphoma really loves to narrow the airway, and see how the right bronchus and left bronchus on this axial CT examination are markedly narrowed. Now that might cause a collapsed lung, but it didn't in this case. This is your lymphoma. This is probably a malignant pleural effusion. So that white lung was due to combination of pleural fluid and parenchymal abnormality. Now, in the following 5 minutes, we'll deal a little bit with some obstructive things, including foreign bodies. So when children aspirate things, obviously, if it's a metallic item, a pin or something, you can see it, but oftentimes it's food, something you can't see radiographically. So you have to decide, well, is there aspiration or not? Now, in an older child, somebody older than 6 or 7, what you do is say, okay, breathe out. And if there's aspiration, you'll see air trapping. The side where the aspirated material is isn't going to get a lower volume like the side that is uninvolved. When you exhale, it becomes wider. So a teenager, say, okay, breathe all your air out. And if it's an aspiration with an obstruction, you won't see that lung on the affected side change. The one thing that we're told to do with young children, because they don't understand, take a breath in, hold your breath, let it out, is to put one side down and the other side down. So with your left side down, your lung should collapse like it does here. With the right side down, your lung should collapse, and you see it doesn't. So this indicates on the cubital positioning on the right, where you'd expect the right lung to do what the left lung does, it does not collapse. So that's the side of your aspiration there, because there's air trapping. Here's another example, a little more obvious in this film here, where this is an expiratory film here and this side doesn't collapse. I think it's just easiest, and I don't know what resources you might have, but it's really easier to do fluoro in these young kids. Fluoroscopy, it's a simple 1-minute examination. And as you can see here, as a child just breathes spontaneously, changes in the lung volume here, gets bigger, the right lung gets bigger, it's bigger than this here. Now it's getting smaller again. Look at the left lung. It doesn't change. It doesn't change. It doesn't change. It doesn't change. So the fluoro, because it's a dynamic examination, lets you determine whether there's air trapping a little bit easier than the decubital films here. Coins. Where do coins get stuck in the chest? They get stuck at the cricopharyngeal level, which is right up here, thoracic inlet, the aortic arch, and the GE junction. A real typical location, the most common is a cricopharyngeus here. One thing you just need to look for and be careful of when you have, say, a coin or something else that's swallowed, is there thickening of the soft tissues between the coin and the airway here. This indicates it's a more chronic process, maybe more difficult to extract. And this was a penny that was lodged here at the thoracic inlet. Remember, one of the 4 levels of obstruction, and you can see all the corrosion here because this had been in for a while. Now let's talk for a minute about a really evil foreign body, and that's the button battery here. And you know it's a button battery because of this beveled edge right here. These are critical to find when they're in the esophagus, and I'll show you why. They can erode and cause esophageal injury, and ingestion, particularly the larger size, are more likely to get caught. Now, if they make it to the stomach or in the small bowel, just because of peristalsis and so on, they tend to go through, although they're followed carefully. But in the esophagus, if they get stuck there, that's when you get the real problem here. So you get that double ring or halo sign here. They need to be emergently removed within their esophagus. And the reason is because now this is some ham here, and this is a button battery, okay? And this is just put on the ham, and then this is folded over. After 30 minutes, look at the necrosis. Look at what's happening after 60 minutes. Now, if you think of this is the esophagus, this is what it does to the tissues there. So this is a really emergent thing. And one thing you need to recognize in terms of foreign bodies is that button battery, typical halo sign. This resulted in a complication of a esophageal fistula here. On a swallow, you can see contrast in the airway. Here's another example. This was a child that had a KUB for vomiting, right? And as I said, that's normally your KUBs start at the lung bases and go down to the symphysis pubis, and we've got much more area covered here. But fortunately, this was a poorly obtained examination, and we saw the button battery in here, and you can see sort of some erosions right here. So the battery itself has been in for a while. And what happened, this is a CT examination, contrast enhanced axial image. This is the aorta right here, and you shouldn't have this little excrescence off the aorta. This was a pseudoaneurysm from a button battery there. And the button batteries can be life-threatening and can have a substantial mortality here. So you need to recognize what these look like and have some emergent attention to these. Just finishing up, sort of obstruction in the abdomen. I talked about this as an older child. One of the more common things that you're going to be asked to look for and look at is small bowel obstruction. Now, if you go back to what I talked about and the things that we look for, which are going to be the distribution of gas, is there wall thickening, is there extraluminal gas, and does it change with time? This is an example of some of those things. So the distribution of gas, this is all small bowel. These are the valvulae contiventes. There are no haustra here. It's central. It's not the frame of the colon. And it's dilated. There are air fluid levels in the small bowel, which you normally don't see. And there's no gas distal. So we've got several of those abnormal gas pattern things I talked about. This would be a classic appearance for small bowel obstruction. If we got another film a few hours later, chances are it would persist here. That is, the bowel gas is not changing, and depending on the clinical scenario for obstruction, would either need to be monitored very carefully if they'd had obstructive conditions in the past, or perhaps have a laparotomy here. small bowel obstruction. So, and I'll just put up this because I think one of the previous speakers, Dr. Maxfield, talked about bowel obstruction in kids, and perhaps we can deal with this in a separate older scenario. And I think Dr. Brown also talked about this. These are the kinds of obstruction you see in kids: adhesions, appendicitis as part of the AIM mnemonic, intussusception, incarcerated hernia, Meckel's, and malrotation. So in concluding here, and I think we do have a few minutes for question and answer, how to read X-rays, adding some color to the black and white. So you hopefully have a good foundation in what you need to look for those basic examinations, the 5-4-3 rule, the 5 things you look for and make sure you cover in the chest X-ray, 4 things with the abdomen film, and 3 things for the extremity examinations. And hopefully it's less hard now when you look at these to recognize these abnormalities. So again, I appreciate the time and talking with you all today. We had some time for question and answer. And if any of you have any questions about interpreting examinations, et cetera, please feel free to email me. My email address is easy. It's my first name dot last name. So Donald.Frush@duke.edu. And you can get my name off of the title slide here, and happy to answer any questions down the road. But let me turn it over to you all now for a series of question and answers, if you have anything. Thank you for your time today.
Thank you so much, Dr. Frush. So if you have any questions, please feel free to unmute yourselves and ask your question, or put your question on the chat message.